let's talk a little bit about resistance and mechanisms of resistance, and let's maybe start first with BCL2 inhibitor resistance, and what do we know about that?
Venetoclax resistance occurs through, there's some mutations that affect the binding of the drug to BCL2, but there's also changes in other anti-apoptotic proteins that confer resistance, and perhaps even other mechanisms that haven't been explored. And the other issue when we're thinking about resistance is also adherence. So sometimes you think the patient's resistant because they're not taking, if you don't take the medication, it's not going to work. So I think less is known about resistance to the BCL2 inhibitors or venetoclax just because it's a newer drug. Whereas much more is known about BTK inhibitors with ibrutinib, and it appears that all the BTK inhibitors share common resistance mechanisms, although there has been a specific mutation described with zanubrutinib that doesn't appear to happen with the other inhibitors, and it's usually mutations in the kinase domain, C481S, and there's also PLC Gamma2 activating mutations, and there's also activation of other pathways that bypass it. So these are all acquired resistance. Primary resistance does occur, but it's rare. So you could, it's rare in CLL, but in other diseases there can be mutations where the requirement for B cell receptor pathway signaling is not so important. So I don't think we're quite at the stage where we can do a gene profile on a tumour and decide, oh, you should have this drug rather than that drug, but I can foresee a day where that may be possible when we get more information on how all these, the genetic complexity fits in the overall treatment schema.
So mutations in BTK and Plc Gamma2 are seen in patients who are developing clinical resistance. I think one concept is monitoring for those mutations, and if that's important, and I wonder if Dr. Ma, you can give us your thoughts on monitoring for mutations, whether we should be doing that, and when testing for mutations in BTK and Plc Gamma2 may be helpful and informative for us.
Mm-hmm. So I think clinically, just finding a small amount of mutation doesn't necessarily need to change your management, but if I'm seeing a patient that I have some suspicion that there might be disease progression, for example, if a patient had previously been very well controlled for a number of years and all of a sudden he's starting to have, maybe just starting to have a rising white cells, or maybe like borderline size lymph node that's starting to get a little bit bigger. It's not like a very clear progression yet, but I'm sensing something's happening. I think that's the time that's most helpful to me to send the mutation analysis. And if I do see a mutation being present, for example, the BTK C481S mutation or the Plc Gamma2 mutation being present, I'll have a very high level of suspicion. I'll be planning my next step. I don't necessarily need to switch treatment if there's no overt clinical progression, but I will have my next step ready when time comes.